Good morning. It's a privilege to be here, and I'd like to thank AIMA for the invitation. I've been given 20 minutes to talk about innovation in healthcare, so I'll do my best to give you a glimpse of where we are headed. But before we do that, just let's step back. Let's step back to 1991. There was no internet. Only 76 million people had access to a phone. We had one television channel called Doordarshan. Chitrahar used to come twice a week, and everybody wanted to see the feature film on Sunday. We had one airline, and our foreign exchange reserves were $6 billion. Turn to today. 460 million internet users, 1.2 billion phones, and in fact, as I speak, some of you might actually be on WhatsApp or Facebook or Twitter. 813 television channels, 21 airlines, $406 billion in foreign exchange, and the third largest economy in terms of purchasing parity terms. So India has changed, and so has medicine. So if we go back, in 1991, we talked about X-rays and ultrasound, and CT had become popular, and there were a few MRIs. Today, we talk about PET-CT, we talk about PET-MRI, we talk about diagnostics at a different level. If someone had cancer and needed radiation therapy, we talked about cobalt. Today, we talk about image-guided radiotherapy, very precise, a few millimeters, and very soon, India will have its Proton Unit in 2018. This is a machine that we are installing in Chennai, which is the most precise and does not give the damage that conventional radiotherapy machines can by going outside the limits of the tumor. About surgery, when I was training, if someone had a gallstone and needed the gallbladder out, he would have open surgery, he would stay in hospital for 4 to 5 days, and that's what was the norm. We moved on to laparoscopic surgery, so you have 4 small holes, go home in 48 hours, then it became single port, you go home the same day, and now with robotics, you have minimal trauma to the neighboring tissue, as a result of which you have greater ability to send patients home soon. So there have been major developments in medicine. But medicine has also become very complex. If you look at the WHO, today we have 13,600 diagnoses. We have 6,000 procedures that are recognized and 4,000 different types of surgeries. And every week a new disease gets diagnosed. We have newer ways of managing that disease and newer types of surgeries developing. We've seen disruption in the way we listen to music. We've seen how we look at money. And let's now look at what's happening in medicine. So this is about digitalization, and I'm going to do this over digitalization. I'm going to look at communication. I'm going to look at how we look at medicine, how we look at surgery, and that's really what I'm going to do in the next 16, 17 minutes. We have a problem. So this is what a typical room that would record medical records for patients would look like. And if you were a patient for several years, then you'd have several files, and then you'd have X-rays, and then you'd have MRIs, and you would have CTs. And you can just imagine the time it took to find it, track it, put it back in. It was a really cumbersome process. But we now have electronic medical records. This is not working. So would you move, or do you want me to try? Okay, I think you move. So now we have electronic medical records. They're available on our phone. People change jobs, they change cities, they change countries. The record goes with us because it's very, very important for continuity of care to have access to your medical record, and the provider can have that. Next, please. We have hospital information systems that are pretty sophisticated. So not only do you have the medical history, you have the findings, but you also have a list of all the medication the patient is on. You have all the lab parameters sequentially. You have the ability to link it to other healthcare providers. We are now in a state where we can provide this to insurance companies, and that can enhance the way we process claims. And of course, there is the financial side which will get added to it in terms of reimbursement. Next, please. Now, if we look at research, and Professor Brahmachari talked a lot about it, but I think artificial intelligence has a role to play. And with digitalization, from the drug manufacturer to the researcher, to the company that's doing the research, to the patient, to the doctors, the radiologists, the lab personnel, everyone comes together in one integrated fashion, which really helps considerably in how research is done. Next, please. Now, if we look at the impact of healthcare innovations, you see that big data is really important. 47% by 2020 is really going to be the impact when we look at innovations overall. Artificial intelligence, and I'll give you examples of that, 33%. Virtual reality, 3%. Robotics, 2%. And Internet of Things, 15%. Next, please. So what can big data do? So let me give you an example, real-time example. You walk into a facility in Salt Lake City, Utah, Intermountain Health System. They run a network of hospitals. So you walk in, you have pneumonia. They have such sophisticated health analytics that depending on which area of Salt Lake City you come from, they know what the community-acquired pneumonia pathogen is and what is the antibiotic that's going to work. So what happens in most hospitals? You come in, you have pneumonia, you get a chest X-ray done, the doctor decides to put you on an antibiotic, we wait for clinical response, whether your blood counts improve, your fever disappears, your symptoms go away. You might have a bug which is unusual, and then only after several days will we know whether the antibiotic was appropriate or not. But at Intermountain, you're pretty certain that you will get the right antibiotic if you come from that particular area because they have such detailed analytics. So big data is really going to change the way we look at medicine and how we can personalize medicine. Next, please. Now, retinal scans. You need an ophthalmologist to look at the retina. Individuals with diabetes, they need to look at their eye health because you can become blind with long-standing diabetes. So you need these retinal scans, but you really don't need an ophthalmologist to do that. You get the image, artificial intelligence, you'd be able to make a diagnosis. Does this patient require medical therapy or is it all right to wait? Next, please. X-rays. Radiologists look at X-rays, clinicians look at X-rays. But with AI, you see that the accuracy is so much more with artificial intelligence. So you don't, in times to come, will feel the need for a radiologist to look at an X-ray. You will need a radiologist for interpreting complicated things, but plain X-ray, not a problem. And that's just the start. Next, please. Now let's look at communication and how we communicate in medicine today. Next, please. So if you get to know that somebody in the family has cardiac disease, you want a lot of information, and we see that in our day-to-day practice. Everybody comes to us with a lot of information. So you go type cardiac disease, and I did that yesterday. You get 53.6 million results in 0.5 seconds. If you type diabetes, you get 30 million results. And even if you're interested in something as unusual as Friday the 13th and medical issues, look at the number of results you get. So there's one hell of a lot of information available. Now the question is, how do you make sense of this? Next, please. Now companies like Google are doing that, and in fact they have these health cards that they've developed for India. They developed it in the US, in India, now in Brazil. So they asked us at Apollo to look at all the data that is available, and then they created this for 400 conditions. So, talk about dengue, talk about malaria. So this is India-centric. How common is it? When do I need to get worried? Should I be going to a doctor, or is it all right to wait? Now, when you go on to Google as such, you'll get confused by the number of data points that you get. But with this health card, you get very precise information. So it's about making sense of the large amount of information that's available. Next, please. Now let's look at clinicians. So if you actually type cardiac disease and go on to PubMed, PubMed is peer-reviewed papers. So all the research that is done that is peer-reviewed and published in papers gets onto PubMed, and this is the US database. So if you type cardiac disease, there are 8.5 lakh papers on cardiac disease. There are 3,76,000 papers on diabetes. And if you're interested in Friday the 13th and medical conditions, believe you me, there are 12 papers even on that. So what, next please, that leads to is that the doctors are also struggling with how to make sense of this information, and this one's really worried because the information keeps changing and the stuff that he knows is the stuff that gets changed. So again, big data analytics is going to be very, very useful for clinicians to be able to make sense of the research that is available. Next, please. Now, Facebook has a new algorithm to spot suicide tendencies. Now, this is very useful because we know that psychiatric conditions are becoming very, very important. And there are people who commit suicide, and there are always pointers to when someone is moving in that direction. So you have an algorithm to spot this among your friends. Next, please. WhatsApp. This has, in some ways, totally changed the way we lead our lives. In fact, you get up in the morning and there are like 300 messages and you don't even want to open, right? But it's actually very useful. So let me tell you, as a pediatrician, I'm a pediatrician, how this is very useful for me. So I have a mother who has a 3-week-old baby, and she's really worried, and she contacts me and she says, "Doctor, my baby's potty has turned yellow And she's really distressed about it because it really worries her. Next, please. So I said, okay, send me a photo. And I know we are away from lunch, so I'm going to show you some potty photos. So if it's like this, I said, it's okay. Nothing to worry. Next, please. And then she says, it's really yellow. And I look at this, no, this is fine. Next, please. And brown is okay, right? It's only if there's blood or it's black you need to get worried. So this is very useful information. She would otherwise have to come, she would get a stool test done, totally unnecessary. Next, please. So you get a mother who's very worried about a rash that her adolescence developed. Now I look at this and I know it's chickenpox. I don't get this child into my clinic and expose other children and other families to chickenpox. Now what is the treatment? It's just going to be bed rest, stay away from school and maybe apply a lotion. That's it, nothing else. So why drag someone out? So it's really useful. And I can't really make this diagnosis without a visual, because the mom can keep describing what the rash is, but you have so many different ways of describing a rash. I see this, my job's done. Next, please. So what we are really looking at is remote healthcare now. So at Apollo, we've developed a program called Ask Apollo. So, it could be by telephone, it could by video con. You're sitting somewhere. The other day I had a patient in Kochi who got in touch with me, and they had a baby with jaundice, and I did a consultation at their home with seeing all the information, with all the reports having been sent to me, and actually looking at the baby. Teleradiology, so reporting X-rays, MRIs, CTs at night when you don't have radiologists. So this is already being done across the globe. So you report when it's emergency time, evening time in America, you do that in India, for England to Australia. So that's happening. But this can happen within the country where you need someone to report an MRI for a shoulder. It's a niche area. There are not that many radiologists who can report an MRI of the shoulder. So you get someone sitting elsewhere to do that. Telecardiology, someone has an arrhythmia, has a problem with their heartbeat. So they have all these 24-hour ECGs. Somebody sitting somewhere can actually look at it and give advice. EICUs, and I'll give you examples on how this is so wonderful. Using remote medical devices for monitoring and using telephony really to be able to give advice. Next, please. Telemedicine is something that's been around, and in fact, Mr. Clinton had inaugurated our first such satellite-based telemedicine center about 20 years ago. Next, please. And let me give you an example how this can actually impact life. So this is beautiful Kaza and Kelong in Himachal Pradesh. Beautiful areas, small villages, very, very thinly populated, remain cut off from the rest of the country for months. Next, please. Next, please. See, this is what the road looks like. So, you have landslides, you have snow, you're cut off. So what happens if you fall ill? You actually need an Indian Air Force helicopter to actually bail you out. So next, please. So the government of Himachal Pradesh asked us to develop a telemedicine program in Kaza and Kelong at 12,500 feet. So the entire team was taken to Chennai. We trained them. Our team then went up, got the technology solution, and we have a functioning telemedicine unit, and I've had that for about a year. Next, please. So the total population is about 3,000, and in 1 year we did close to 4,000 consults. But what was very gratifying was 317 emergency consultations. Next, please. A few weeks ago, someone walked in with an arrhythmia, and he needed cardioversion. Now, the technician had been trained by our team in Chennai, but he had never done this procedure in several weeks. So the team in Chennai asked him how to do this. He did the cardioversion, and the arrhythmia reverted. This individual would not have had time to wait for a helicopter to get him. And again, telemedicine can actually save lives. Next, please. The government of India, as you know, has about 150,000 common service centers across the 600,000 villages. So about a fourth of the villages are covered. So in 60,000, there are teleclinics. So what's happened in these CSCs is that telemedicine is a solution. So for 100 rupees, you can actually see a neurologist in a remote part of the country. Now just imagine the cost benefit. So someone in a small village would perhaps need to go to Varanasi. 2 people would travel, he'd miss a day's wage, the cost of the transport, only to be told that you have a tension headache and all you need is a paracetamol, right? So sitting in the village at 100 rupees, you can actually see a neurologist, and we've created a hub in Hyderabad for this. Next, please. And this is great for diplomacy. As part of the Central Asian E-Network, this is our Prime Minister sitting in Bishkek, and the consultation is actually happening at Apollo Delhi for a patient from the CIS. So this really helps you bridge the geographical barrier. Next, please. This is an EICU. So it's a very small space that you need, maybe 10 feet by 10 feet. And you can connect with a large number of ICUs. So what do we do is there is a camera at the ICU that is remotely connected. All the information that a clinician needs, from his ECG to blood pressure to pulse rate to everything, including the blood tests, and if you're on a ventilator, what is the oxygen delivery, what is the FiO2, what are the settings for the ventilator, are available to the screen. So you want to see the patient, you shift the camera onto the patient, you see that. You want to talk to the doctor, you shift the camera to the doctor. Next, please. So we've connected 110 beds because there will never be enough intensivists in the country to manage the number of ICU beds. So 110 beds across 12 hospitals in Andhra Pradesh connected. You have an ICU doctor who's sitting on his chair and monitoring 110 patients and giving real-time advice. And what we found, there was a 23% decrease in average length of stay in the ICU because of optimal care, and definitely a decrease in adverse outcomes. Next, please. Next, please. So if you go back to about 200 years ago and you see what a prosthetic limb looked like and see what a prosthetic limb looks like now. So this is about innovation over time. Next, please. Next, please. And we've seen that, we had Oscar Petronas actually win an award with this limb. Next, please. Let's look at endoscopes. So, you had those rigid endoscopes and then you had flexible endoscopes. Next, please. And this is how I was trained. So someone was training me and I was looking with one eye closed on how to do endoscopy. That's the way it was taught. And that's the image you had, one eye closed. That's what you were looking at. Next, please. And this is one of my fellows doing an endoscopy at the hospital. The scope's much thinner. You actually have the full screen in front of you. There's no strain. You have the stability of your hands and you can do a much finer job and also train people. Next, please. And now we have this pill. So this is the size of, it's about 2.5 centimeters. You swallow this, it has a camera developed by the Israelis. So you swallow it and it takes images in the small intestine where you can't really get through an endoscope. So we take the recordings, we look at it, the computer, we can look at the inside of the small intestine to look at tumors, you look at inflammation, look at infection. The capsule gets passed usually the next day or 48 hours later. Next, please. You have innovations now in diagnostics like a liquid biopsy. So glioblastoma multiforme is a dreadful type of brain tumor to have. It has very guarded prognosis. Most people will die in a few months. But to make this diagnosis, you need an invasive brain biopsy. So you actually have to put a needle in the brain and take a biopsy. But we now know that the glioblastoma multiforme tumor sheds out tumor cells in the bloodstream. So if you picked up those tumor cells in the bloodstream, you could make a definite diagnosis and save someone an invasive, painful diagnostic test that has side effects. You could have bleeding, you could have infection. Next, please. We now have 3D printed spine. We can look at the vertebra and create it based on the anatomy of the patient, and it's commercially now available. Next, please. We will soon have digestible sensors, so you swallow them in, you'll be able to actually look at whether you have cancer of the food pipe or not. And this is happening in other organ systems as well. Next, please. So let's go back to X-ray. So, you go back to 1939 and, there's a chest X-ray, a fancy, complicated machine. Next, please. Then we moved on to fancy CT, so you can get precise images. So this is a 612 slice CT scan. So you can actually get a heart image in a few minutes that can actually tell you whether you have plaques in your arteries or not, and you actually don't need an invasive angiography. Next, please. And then you have MRIs. But what about big MRIs for children? That's so hard to do. So you now have baby size MRIs for babies. And clearly we're going to see technology become so superior that the size of these expensive machines will go on decreasing, whether it is a CT or an MRI, and there's a lot of interesting work happening. Next, please. So this is a cobalt-60 radiotherapy machine that was used. Right? So it did burn the tumor, but it burnt a lot of healthy tissue around the tumor. So you had numerous side effects. So if you were, say, looking at a tumor in the urinary bladder, you would get severe urinary symptoms because the healthy bladder would also get irritated. So what we needed was more precise ways of delivering radiation. Next, please. So we got linear accelerators. They produce a whole lot of energy. They're very precise, a few millimeters here or there, so you don't produce damage. So imagine if you have something in a part of the brain where next to that tumor is a crucial part of the brain that controls your speech or your hearing or your vision. You don't want trauma damage to that part. Next, please. And very soon we're going to have the Proton Unit. So the Proton has amazing advantages in certain types of tumors like head and neck, breast, genitourinary, and very importantly for children because it doesn't expose them to radiation. Guess what this machine costs? It costs 500 crores. And the first of its kind will be installed by us in September. So all this technology is available, but it's incredibly expensive. Next, please. Otitis media or an infection in the ear is a common problem. So you need an antibiotic if you have otitis media. So all that the mother needs to do is take a photograph, send it to the database. It's otitis media. You need an antibiotic. What's the antibiotic? Next, please. A live core is a device that looks at ECG. So instead of those elaborate ECG leads, all you have to do is put your fingers on the sensor. The ECG, medical grade ECG, goes to the command center. A cardiologist interprets it and tells you, do you have a problem, you don't have a problem. And sometimes when you have arrhythmias, you have to run to a cardiologist because suddenly you're getting a heartbeat that's slow or very fast. And you can do this at home. Next, please. Eye netra. You don't need to see an ophthalmologist to actually get your eyes looked at, your numbers changed. Well, it can be done digitally. It's as good as an ophthalmologist doing this. Next, please. So let's just spend a minute or two on the genetics. The DNA was first identified in 1953, and every 15-20 years there was progress. And then 1994, we got one example of gene linked to cancer, which was BRCA1, BRCA2. Next, please. So now we know that if you have BRCA1, there's a 60% chance of breast cancer. With 2, it's 45%. Ovarian cancer, 39%. 15% with BRCA2. Now you might say that how does it impact the average person? Well, it does. Next, please. Angelina Jolie decided to go in for a prophylactic mastectomy because she had an 87% risk of breast cancer, 50% risk of ovarian cancer. So we are now moving in genetics actually predicting how we preempt diseases from developing. Next, please. Now, if you look at what it used to cost to decipher the genome when it first started, 2001, $100 million was spent on it. And look at where it's come down to $1,000. So at $1,000, and it will come down, each one of us has our unique genome. We will be able to know what our genome carries at about 50,000 rupees. Next, please. Now, what is the implication for this? So, you have a gene chip for certain diseases. If you have this, if you have a particular disease, you check and you have the genetic basis for it, can be done at the bedside. Next, please. So, when a lady is pregnant, there will be circulation in her blood of the genome of the baby. So you can actually take a blood sample, do the whole genome sequencing of the baby, and you can actually predict if that baby is going to have a disease or not at birth. Next, please. At birth, you can do risks quantification. Of course, this is work in progress. There are lots of gray areas still, but it's possible, and this will evolve. Next, please. You actually might be able to, based on the prediction. For example, we know that those who become criminals have a particular type of gene. Right? So you can actually look at a 3-year-old and decide, okay, he's really going to be cut out for becoming a lawyer because he has XYZ kind of genome sequencing. So we're actually looking at that happening. Next, please. Roger Moore was a very, very popular James Bond, wasn't he? And the reason why I'm showing you his photograph is because of the condition he suffered from. Next, please. In 1993, he was diagnosed with prostate cancer. So there were 5 options for managing prostate cancer. Radical prostatectomy, you remove the prostate, you remove a lot of tissues around it, lots of problems with incontinence, you lose bladder control, and so on and so forth, other side effects. Active surveillance, do nothing. Low dose brachytherapy by actually putting the radiation beads in the prostate. High dose brachytherapy or external beam radiation therapy. Next, please. So Roger Moore being Roger Moore, he took multiple opinions from the top doctors in the world, and this is what he said: there are bits of me in specimen jars all over the world. I just hope there'll be enough of me left to put in my coffin when I die. So he went in for multiple opinions. Next, please. and he decided to undergo a radical prostatectomy. But he underwent an open radical prostatectomy with numerous side effects. Next, please. So today, if he would have opted for a radical prostatectomy, it would have been done robotically, where the patient is away from the robot and the doctor is actually working on the robot, and it's the robotic arms that are actually doing the procedure. And because he's sitting, he's not tired, he does not have any movement artifacts, because when you're standing for hours, your hands tend to get a jerk. This is on a table, and the side effects are minimal. So in today's world, the standard treatment, if you have to have prostatic surgery, radical prostatectomy, it's by robotics. Next, please. But 50% of all those diagnosed with the tumor Roger Moore had would actually have no treatment today, and they would be under an active surveillance program. So see how much things have changed. Next, please. We now have some amazing medications to look after some very rare conditions, extremely expensive. Familial lipoprotein lipase deficiency leads to cholesterol problems. Paroxysmal nocturnal hemoglobinuria, you pass hemoglobin in the urine. Or Pompe's disease, which is a type of a muscular disease. So for each of these, we now have specific therapy. Next, please. And one of the big things that's happening in cancer therapy is personalized cancer. Just because you have a particular type of tumor does not mean that standard treatment will work. You really have to look at the genetics and decide on what type of therapy to be offered. So CAR T therapy, we have B type of lymphocytes and T type of lymphocytes in our bloodstream. So you look at the cells, the T cells, modify them, inject them back into the patient, and these T cells from the patient will attack the cancer cells. Next, please. And this has now been commercialized. The first FDA-approved CAR T therapy for acute lymphoblastic leukemia in children has now become available. Next, please. Gene therapy. Now, we've talked a lot about genomes, so we know that a lot of conditions that we have get established because there is a defective gene, so it doesn't manufacture a particular protein, or there's a deficiency of an enzyme. So if we can correct that gene, we will prevent that disease from developing. Next, please. And then, of course, we can also look at the level of the mitochondria, and this has relevance for certain conditions because of the way they spread or go from one generation to another. Next, please. But it's also about being able to do some interesting path-breaking surgeries. Now, this child has a rare condition called Nemelin rod disease. He comes from a village in Madhya Pradesh. He spent his entire life looking at the world upside down. Nobody would play with him. He couldn't go to school. He had the most miserable life possible. Next, please. This is him after his corrective surgery 3 days later. Next, please. Next, please. This is him 4 weeks later. Channel 4 did a video on him, a full 20-minute documentary, and for the first time he's running around playing with his friends in his village.
Is it done by Apollo?
Yeah. Next, please. It's about separating these twins from Nigeria. Next, please. It's about separating these twins from Tanzania. Next, please. Next, please. Next, please. It's also about understanding organs better to be able to offer therapy. So this is what a liver looks like, and I don't know how many of you know that while the liver has the right half and the left half, but there are 8 parts to it. Each of these parts have their own blood supply, their own bile ducts. So you can actually take, if someone needs a liver transplant, take 2, 3, 4, 5, 6, 7, 8, 2 or 3 from a healthy person, because like a lizard's tail, the liver regenerates. So in 12 weeks, 90% of what has been taken would have come back in the individual when we measure by ultrasound. Next, please. So if you need a transplant in an adult patient, you will take the right lobe. Next, please. If you have a child, you will take the left lobe. If you have a smaller child, you will take segment 2, 3 of the left lobe. And if you have a baby, you will just take segment 3. Next, please. So you can actually fit the liver of a father in the baby. And this is a very moving story from Anand in Gujarat. This baby came to us, and this baby had liver failure. The family had had one baby after 10 years of IVF, and they decided 4 years later to have another baby, and they had twins. So one twin was fine, the other developed liver failure, and we transplanted this child at the weight of 3.75 kilos. And he got a part of the liver from his father. Next, please. This child had a unusual condition in which he had kidney failure, but the kidney failure developed because of the absence of a gene in the liver. So replacing a kidney would not help because the oxalate, which is what he had, would come back in the new kidney. So he needed a combined liver and kidney transplant. Came to us from Sudan. Luckily for him, he had twin sisters. One's a doctor, she gave the right lobe. The other's an engineer, she gave her kidney. And this is a child with a combined liver kidney 2 weeks after a transplant. Next, please. And again, I want to tell you how technology has changed things. About 6 weeks ago, I got a call from a father in Dhaka, and he said, "Doctor, I've been told that my son has liver failure. He's not recognizing me anymore. They say his clotting is abnormal. He needs a liver transplant. Can you help him?" And I said, "Sure, we can, but we'll have to send a plane because a commercial plane will not take this child." So the mother was going to be the donor. Our High Commission gave a visa in 3 hours. We had a plane ready at 5 a.m., but if you notice, there are lots of clouds over Bangladesh. And this is 4:13 a.m. So we waited for the clouds to clear. At 9 o'clock, the plane took off. Next, please. The plane landed at 12:30. Obviously, our team didn't have visa, so there's an ambulance with the child. We get the child into the plane. Next, please. We track real time on where the plane has reached. The plane reaches Delhi at 3:15. We get the child into the ambulance. I see the child at 4:15. He's really irritable. I put him on a ventilator, start dialysis, start controlling his blood pressure. 36 hours later, he has a liver transplant. Next, please. He recognizes his father 3 days after a transplant. Next, please. 2 weeks later, he goes home. Now, this would not have been possible if we didn't have technology. Next, please. And as I end, I want to end with this story. This is Sanjay. He was born in Kanchipuram and had liver failure. And this is him at 18 months. And he needed a liver transplant, but a liver transplant had never been done in India at that point in time. So the father came forward. The child had a liver transplant. This was the first time we were doing a liver transplant. He had a very rough time. He was on a ventilator for 8 weeks. And he had multiple surgeries, ICU for about 9 weeks. Next, please. And we were really delighted when at 100 days he went home. This is with his father, the donor. Next, please. This is the same child a year later at the All India Transplant Games with a much younger Chandrababu Naidu, who was then the CM. Next, please. This is the same child 3 years later. Next, please. This is him 12 years later. Next, please. This is him on the cover of Week magazine 15 years after a transplant. Next, please. And this is him now, a third-year medical student. We just celebrated 19 years of normal life. So this would not have been possible. And this is about innovation actually touching lives. Next, please. And as I end, I want to go back to Prince. And sadly, Prince passed away last year. So Prince was a pop icon. And in the mid-90s, he made a declaration one day. He said, "The world has changed so much, there is no need for names. So from tomorrow, I will not be known as Prince," but next please, "but by this symbol." So everybody went into a dizzy, his media label, and the journalist, how can you replace a man's name with a symbol? So they actually created a name. Next please. They said, "Prince is now Tafcap, the artist formerly known as Prince." Next please. And I think the way healthcare is evolving, we now need to change the narrative. It's not about patients. Next, please. So we should remove this and we should now move on. The individual formerly known as a patient, next please, but now a partner. And I think the moment we look at as a patient, as a partner, the way we look at things changes. Next, please. And as we get high tech, it's very important to remain high touch. And I will end, next please, with a story that a friend told me, and she's in America, and her mother, who was in her 90s, was admitted in hospital, and the team said that the time has come now where she's going to deteriorate. Her kidneys are going, she will need to get onto a ventilator, she will need dialysis, so I think you should call everyone together, all your siblings. So they're a large family, there were several siblings, they came from all over the world. A meeting happened and the intensivist says, "No, next step is this, dialysis, ventilator, so on." So the family physician who was caring said, "But what will mummy want?" Had anybody asked mummy what she would want? And the question was, nobody had. So everybody went to mummy and said, "Mummy, what would you like?" And she said, "I don't want no dialysis. I've had a great life. I don't want to be in a ventilator. I want to go home. I want to spend my last days with my grandchildren looking at the photo album." And that's what they did. The family came together. She died 2 days later, but they were all together. And my friend said that day I realized that my mother had two doctors. She had the intensivist who was amazing, who was doing the right things, kept her going and would have kept her going. But he was the doctor of the body. But then I found the family physician as doctor of the soul. And I think what we need in medicine today is doctor of the mind and doctor of the soul. Thank you very much.